Before we get cracking on Jill Maddison's podcast, what I wanted to share with you or talk to you about was the Unleashed online conference that myself and Hubert are heavily involved with and we're organizing. So I'll give you a bit of a rundown what it's all about. And essentially, over the last 8 years, I spent quite a lot of my time developing clinical resources, thinking that the more that I empowered the veterinarians that I was mentoring with clinical knowledge, the better able and equipped they were to cope with the stresses of being an emergency veterinarian. But the issue we found was that for some veterinarians, no matter how much clinical knowledge that I imparted across, there was still this level of underlying doubt, anxiety, just some kind of barrier that they were trying to overcome. And I felt like as if I wasn't providing the information that they needed in a clinical aspect. And that's where I realized that actually clinical knowledge plus something else is what actually results in success. So what I've done is I've gathered 7 of my best friends who have succeeded in different aspects of their careers and got them together in a online conference format so they can share what they've learned. Anthony is a behavior expert and expert speaker, and he's going to talk about confidence and confidence in the way that you communicate, which is an incredible skill and also incredibly important in the consult room. Shibley is going to talk about self-awareness and how that plays an important role in the way that you communicate, and also talks about wealth and how to demonstrate value to clients. Brooke is going to talk about social media, specifically on Instagram, and how she used that to share her message and have impact with her audience, and also how to deal with failure and imposter syndrome. Hubert's going to talk about the golden nuggets from the Vet Vault, so the key things that the mentors that we've got on the Vet Vault have shared, and also an aspect on personality. What is your social style and how the social style impacts the way that you communicate in consults and how you can leverage and flex your style. This is an incredibly important skill to understand and can have dramatic impacts on the way that you interact with clients and fellow team members. Alex is going to talk about the elusive work-life balance and then also how she connects in the consult room. So she'll share her secrets on how she connects in the consult room. I'm going to talk about clarity and trying to find clarity in where you're heading over the next 2, 3, 4, 5 years. Because if you know where you're heading, then you can make a plan for that. And then once we understand that, we're going to set you down the right pathway. The Dean's going to talk about resilience because we need you guys to swing back and bounce back from adversity. And then Sarah's going to talk about supercharging your impact and influence. So everyone wants to have an impact. You may not realize the impact you want to have, but we're going to discover that. And then how do we get that and maximize your impact on yourself, your local team, so your team within your hospital, and also your wider community and beyond. So in the show notes will be a link, or if you go to our Instagrams, you'll find that there will be a link there for the Unleashed online conference. And on the website, you'll find the speaker pack, but also the tickets, which are now available. Are you ready to rock and roll? Good evening, ladies and gentlemen. This is Gerardo Poli.
And this, sorry. Okay.
One of the best bits of advice I've ever received was to find good mentors and to learn from them. Trusted people who have already done what you're trying to do now. I've been fortunate throughout my career to have some fantastic mentors to help guide me, but I realized that they'd be hard to find and also hard to commit the time to one. This is why we've gathered some of the best minds from the veterinary world and squeezed them for their wisdom so that you don't have to learn the hard way.
With the help of our guests, we flip the veterinary profession on its back and explore its soft underbelly to find the tips, tools, and inspiration that you'll need to build the career that you've always wanted.
I'm Gerardo Poli.
I'm Hubert Hemstra, and this is the Vet Vault.
If you don't know who Jill Maddison is, then you're missing out, but that's okay because we'll fill you in this podcast. Jill is currently Professor of General Practice, Director of Professional Development, and Director of the Bachelor of Veterinary Medicine course at the Royal Veterinary College in the United Kingdom. She is actively involved in undergraduate teaching and continuing professional development at the Royal Veterinary College in the areas of small animal medicine, clinical problem solving, and clinical pharmacology.
She has lectured extensively around the world on clinical problem solving, small animal internal medicine, and clinical pharmacology. If you've ever listened to one of her lectures, you'll know that she is the epitome of clear-minded scientific thinking. And if you haven't had the privilege of hearing her speak, well, luckily, she has a book just for you. Jill is senior editor of a book called Clinical Reasoning in Small Animal Practice, which is the best guide to clear thinking about small animal medicine that you are likely to ever read. She's also published over 60 refereed papers in veterinary and medical journals and is the senior editor of a previous book, Small Animal Clinical Pharmacology. To keep in touch with the realities of private general practice, she consults at a local veterinary practice at the RVC's First Opinion practice, the Beaumont Sainsbury Animal Hospital.
In this episode, we talk about clinical vet work for a change. Jill talks about some common mistakes that many vets make when it comes to clinical decision making and why curiosity and thinking skills are more important than knowledge of the facts. Jill gives her insights about the value of internships and tells us what her favorite textbooks are for everyday practice. Please enjoy the Queen of Veterinary Small Animal Medicine, Professor Jill Maddison.
So Jill, I've seen over the past 10 years or so since moving to Australia, I've actually seen you speak at a couple of congresses. I was much impressed. It's always a sense of just absolute confidence and certainty with what you're saying. I've actually joked with colleagues before, if you're having a clinical disagreement, if somebody says yes, but Jill Maddison says this, that ends the conversation. There's no comeback from that one. So I must admit, when Gerardo said we've got an interview lined up with you, I was a little bit intimidated. Felt like I was interviewing veterinary royalty. But then I Googled you a little bit and what you've written and what you've done over the years. And I realized it's not veterinary royalty. It's more like a veterinary superhero more than anything.
Just a very long time.
So my first question is: were you born a superhero like Superman, or did it happen later in life, more like Spider-Man with a radioactive spider bites or something?
I know you're not supposed to say that as female. I've always been very bossy, so I was school captain at my primary school and at my senior school, so I suppose that means I don't know.
Were you always a very committed, driven sort of a person, or is it something that happened as you developed in life?
No, I think I was probably fairly committed and driven. Yeah, I don't know what by.
They talk about some things, and people as they progress through their careers, and they a lot of successful people, they have this bias, and they call it the bias for action. Do you feel that, like, as you were going through high school, as you're going through university, like you saw things and you wanted to contribute, so you took action as opposed to the kind of person who would just see things and then let other people do?
Yeah. So I always got involved with things. Being class captain, being school captain, being on the SU, the student, council for school. Although that experience put me off any involvement in university politics, because I can't even remember what the details are now, but it was some fairly sort of difficult things happened, and I thought, I don't want to get involved again. Although I think I was one of my year reps at university, but then being involved with associations, so getting involved with the ASAVA was my first step, because I remember being in Perth at an ASAVA conference years ago, going just as a delegate and seeing the committee and stuff, and I thought I really like what they're doing, and I like what they're doing for small animal practice, which the AVA wasn't doing at that stage, and I thought I'd really like to be part of that. So that's where I did a lot of my leadership development, was initially through the ASAVA, a lot through the ASAVA for years, but I was also on the AVA board. So I guess I I'm not one of those people who moans about something and then doesn't do anything about it.
Okay. And just to recap, you studied vet in Sydney, is that correct?
Yes.
Where did you grow up? Where are you from?
Sydney.
Are you from Sydney?
Sydney.
And then how did vet happen back then? Why vet? How did the journey happen?
So I always liked animals, liked writing. So but I didn't start vet. I started animal behaviour or behavioural science at Macquarie.
Mm-hmm.
And my father was a doctor, and I knew I didn't want to do medicine for whatever reason. But I think he was a psychiatrist. I kind of went to the behavioural side of it. And then when I was at Macquarie, it was okay, but this will sound really arrogant, but there was one assignment that I did when, you know, I was not at all on top of my game. In fact, was probably affected by all sorts of things at the time. And it got this amazing mark, and I thought to myself, I need to be more challenged than this. This is too, not too easy. It was just, but I need more challenge than this. And then I honestly can't remember. I then applied for vet, but I literally cannot remember what the thought process was. I know my father got me to meet with a friend of his who was Professor of Veterinary Anatomy, Rex Butterfield, who's this just wonderful man. And the idea was that I would have lunch with Rex, and Rex would talk me out of being a vet, which of course didn't work because Rex was a passionate vet. So so that's how I got into vet. But I went into it thinking, having no experience of vet whatsoever. I think I'd been to the vet once. Yeah. Thinking I was going to be an equine vet, that it was sort of all about horses, which didn't work out that way. But yeah.
Did you go into horse practice or something? Or?
No. I started vet, and that was kind of why I thought I was doing it. And then about in third year, I got really sort of enthused about native wildlife and went tagging kangaroos out at Tibooburra. But as soon as I walked into the small animal clinic at Sydney and discovered medicine and probably started lectures in medicine, then that was it. That's what I wanted to do. So then I had a very focused, for quite some time, that what I wanted to be was an academic small animal clinician, medicine clinician.
Was that from a love of knowledge and a love of learning, or?
I don't know. It just clicked for me. You know, surgery didn't click for me at all, and I hated anatomy, and I could never remember anything. And then the medicine stuff, it just clicked, and I liked it, and it made sense. And I didn't have to really study it very hard because I just remembered it. And then I really liked in final year, because we had 2 clinical years. In final year, I really liked dairy practice, because it was scientific and evidence based, and you know, whereas I didn't like equine practice, which was sort of more kind of fire engine-y stuff and things like that. I didn't really go off equine practice. It was because I didn't really know anything about it. I mean, I did EMS or practice, and it was fine. I had a fine time, but I wanted the evidence base and the problem solving and we had very good mentors. I had very good mentors in small animal medicine. So.
I understand what you're saying about kind of just things just make sense. Sometimes when you get down enough and you know enough about the underlying disease process, then the management makes sense.
Yeah. I keep saying to everybody, you know, if you know your pathophys, then you can work most things out, and that's what I quite liked. And I think I was mentored really well, and had really sort of good mentors who were inspiring and they were teaching medicine in a way that was different from anywhere else. Well, I now realise different from anywhere else, and it just worked for me. So.
So this was at Sydney while you were doing your degrees.
Yeah.
Different in a way, because has that sort of shaped the way, because you wrote a book in clinical reasoning. Was it delivered in a way back then that was problem based or?
Yeah. So when I was in fourth year, one of my mentors, Brian Farrow, he had been doing a sabbatical, and he had worked with Sandy De La Hunter, who was teaching neurology from a very logical, neuroanatomical, but makes sense type way. And he came back and said to the other medicine, because there are only 2 medicine lectures in those days, to the other medicine lecturer, David Watson, there must be a way that we can use this kind of approach in other body systems. And David said, yep. And so David taught particularly GI, from a problem-based way, which was the start of what, and so then I was taught that way as a student. I then, because I did an internship there, it was reinforced. And when I did my residency, I reinforced it, and it just evolved over time to be more explicit. And I think a little bit more practical, because I think David was wonderful in what he knew, but he was very detailed, and he tended to make it a little bit inaccessible, that in sort of general practice, it was a bit too very detailed and a bit too, you need to know all of these differentials for the problems, and so it put people off. Mm-hmm. So I guess what I did was manage to move it into something that was a bit more accessible and usable and you could do. But they, they very much, mentored me that if you're understanding pathophys, then you're going to, it makes everything a whole lot easier.
Oh, yeah, pathophys, I'm not a specialist, but I'm my members and I did my masters, and a lot of it was pathophys. And when you go through it at the start, if you don't really appreciate how important it is to understand, how disease occurs, you kind of get lost into why you treat. You can learn treatment pathways and just diagnostic pathways through the pathways, but then if you don't really understand why you're doing those things, it doesn't really complete the circle. Yeah. You don't remember it. It just you
don't remember it, and it's sort of, whereas if I remember when I was studying for my fellowship, and I thought, right, I've got a bit of a study plan here, and I thought, well, what I'll do is I'll start with the body system I liked the least, which was cardiovascular. And then so I studied that and thought, right, well, I need to do the pathophys for it. And then I thought, oh yeah, this makes sense. It's really, okay, that's why you do that, and that's why you do that, and that's why you do that. This is what the body's trying to do, silly old body, it's doing the wrong thing. You're trying to sort of stop this, and this, and then it sort of made a whole lot of sense.
So you went from uni straight into an internship at Sydney. Is that correct? Or
yes, I did an internship the first year I was out. I did a locum in Darwin for 3 or 4 weeks to earn some money. Mm-hmm. And then I did an internship at Sydney for a year. Yeah. It was a rotating internship through the different disciplines. And then I was in practice in Sydney for 18 months. Okay. And then I went to my residency as well.
Which is Canada. You went to Canada?
Yeah, I went to Canada, yeah.
Canada, okay, cool. That's quite a journey. And then back to Australia again, and then to the UK after that. Am I following the story correctly?
Yeah, I came back to Australia. I was thinking about doing my PhD in the States, and I was thinking about doing a combined clin path residency and PhD at Davis. And then I decided that I didn't want to be an expat, which is very ironic because I'm an expat now, but at the time I didn't want to be an expat. So, and it was really hard to get academic jobs in Australia, but I thought, oh, well, I'll just go back. I know I have to do a PhD to get one. Yeah. So I did a PhD because to me, it was a step to getting an academic job. And so I thought, I'll do it back in Australia. Yeah. And so that's when I went back, and then was there, I guess, I went back in 84, beginning of 84, end of 83, and then did my PhD, and then sort of had various positions there, and then ended up here, but that's a whole another story. So.
What you mentioned there when you were discussing was a pretty long process, and was that did you have an endpoint in mind? Was that what you wanted? You talked about you wanted to be an academic in medicine. And maybe that's similar to what students are like. They want to be a veterinarian, but then when they're in there and immersed in it, it's almost like they're at the foothill of Mount Everest, and it's too hard to get to. And that whole looking up can be so overwhelming. How did you tackle that? Because that's years of process there.
Yeah, I mean, well, first of all, you have to accept it as it is. Like people who say, I really want to be a specialist, but I don't have the time or whatever, or then they don't really want to be a specialist. Or they get it. It doesn't, it's the same today. It's the same process. I think what's interesting is that that's what drove me. And yet if I look back at my career, I've only actually spent 3 to 4 years as a full-time academic clinician in a specialty hospital because what I realised was it kind of in a way wasn't enough in lots of ways. I don't know. It's sort of, I just got to the point of saying, maybe it was 100% clinical commitment and you weren't given time off clinics. I don't know, when I think about the sort of decisions I made, I'm not exactly sure they were really thought out, but except that my passion is still academic medicine and I love medicine, but now I like to translate it, I guess, more. I'm much more interested in translating it and making it accessible in general practice than I am in the fancy stuff that happens. I used to love the fancy stuff that happened, but I was always much more interested in the problem solving, the diagnostic dilemma, not the treatment dilemma. I'd lose interest once I'd made the diagnosis.
I love that what I can do in the first 12 hours, but then someone else can.
Exactly.
That's exactly how I feel about it. As you say, it's like a mystery that you get to solve. And once you've solved it, you go, okay, now it's boring, now bugger off.
Exactly.
Go see somebody else. Okay.
Do you think that maybe, and maybe this is the reason where you're at now, it's you have a big impact for that one patient, and that's exciting, but then maybe the biggest impact you can have now is actually helping students process. And like if you can do that for 300 students a year, but through resources, do that for thousands of students a year in a systematic kind of manner, which helps break down the challenges that are faced with diagnosing disease and fast tracking that process for them. Is that now?
Yeah, I mean, I think that the teaching thing came because I always really enjoyed working with students in the clinic. So when I was a resident, I really enjoyed it. I think I probably recognised that the way I thought, which is the way I'd been taught, the problem-solving stuff, worked really well as a scaffold for teaching. But where it started really was through the what was called then the Postgraduate Foundation, is now called the Centre for Veterinary Education in Sydney. And so when they started their distance education program, Doug Bryden asked me to do one on problem solving. So I've been doing that for a very long time. And that's where, through all sorts of reasons and routes, it really got honed, because I had to create this course, which is a distance education course running over a whole year with lots of resources. No online then, this is 25 years ago. Doug had this sort of vision, so it was very new, sort of no one was really doing it, and he had this vision that the tutors needed real educational support to be able to change what they were doing, because it's one thing to stand up and give a lecture, but now you've got all this material that someone's going to be reading and how to make it engaging. So he engaged as a consultant a woman called Julia Atkin, her area is education. She was married to a vet, which was kind of serendipitous, but her area was education, particularly primary school stuff. And we worked with her for years, and she was my greatest learning mentor. And because the way she'd done her PhD on different ways that students learnt chemistry, essentially from a problem-solving version versus a traditional version. So what I was doing with my course, she really got, and so we worked really well together. I mean, she was amazing for everybody, actually, all of the tutors, and as the program got bigger. So, but that's where I got a number of things. One was I got amazing education training, which I had got nothing at Sydney as a lecturer. The second was that it absolutely, totally reinforced to me how needed it was and how valuable it was and what a change you could make for people. So when I did it, I can remember the very first year I did it, and I had put it all together, and I was convinced that it needed to be this problem-based approach to the clinical signs, and that the knowledge stuff about intricacies of disease was just not part of it, really. People could look that up, but this was about structure. And but there were loads of people who didn't agree, thought it's too simple, and so I was, oh yeah, I'm convinced I'm right. And then the first assignment that came in was from this woman in Melbourne, and it was brilliant. Like, it was, she had written her case assessments and they were absolutely amazing. And I can remember sitting there going, I have got this completely wrong. I have got this completely wrong. People don't need me at all. Anyway, she was the best I've ever had. So she just happened. It became very apparent that it was needed. So the years of doing that absolutely convinced me. And as the course was always sold out and there was on waiting lists and people committed all of this money to do it, a huge amount of time and effort, and what I got out of it, and people would tell me that I had, the course had saved them from leaving practice and all that sort of thing. So I was so convinced it was right that sort of drove me forward. But that's where it got really honed, and it also became what I call my virtual practice, because the participants, not all of them, but most of them, will write up cases, and I can use them, and I know they've been solved in general practice. So in my teaching, I can give a case and say, this has been solved in general practice. It hasn't been solved in a referral centre. It's been solved in general practice. So you can do, you can do, so it's sort of, yeah.
So is all of this culminated in your book, in the clinical reasoning in small animal practice? Is in that book? Is that an encapsulation of everything we're talking about here?
Yeah, I mean, so essentially that book, some additions from some other contributors in areas that I'm not, as strong about, but that book came out of the notes that I wrote and still write for the distance education course. So it's a distillation of the distance education course. Actually has more copious notes and more things about treatment and drugs and things like that. Yeah. But it's a distillation of, that's where it came from. So it's a bit like the therapeutics book I've got. So clinical pharmacology, small clinical pharmacology, which is my other book, that came from the notes I wrote for the students at Sydney when I became a lecturer and then senior lecturer in clinical pharmacology. So I wrote all these lecture notes and used them when I gave lectures, and I went, oh, well, I might as well put them together. And I think it started, I did a little book for the CVE, therapeutic update or something, in one of their little books that they used to do. And so it developed from that too.
I remember there's these little things used to come out and a little.
Yeah, I don't think they do them anyway. They've got different proceedings, but I don't think they do those updates.
Yeah, I saw a whole library of them when I was at uni, and it was just like this, like.
Oh yeah, they've got That's all of the proceedings from their courses and things. So,
but there are also some places. Wow. Like I can see now, like a lot of where the underlying drive comes from, or where your focus is now. So.
Yeah, I suppose it because I was doing it so much with vets, be it face-to-face or distance education, but it's been a really slow burn in lots of ways, because it's not so much now. My analogy is that the more sophisticated the society is about small animal practice, the more they actually recognise that the thinking skills are needed. The harder sell is to sell this, not necessarily into other, because there are some, for example, Asian countries I work with where there'll be really visionary people in their associations who get the fact that there's no point teaching people about ultrasound if they don't know how to think about a common dog. But there are lots of other areas of the world where what they want is, they just want to hear about, really fancy stuff, and that's what they see as CPD. So it's interesting, because it's really only now in the last few years that the dialogue around veterinary practice has really shifted to say, this isn't about what you know, it's about what you do with it and how you apply it. And so your clinical decision-making and your professional decision-making, which is another thing we focus on a lot at RVC, and have got, it's taught by Liz Chan and her team. That's now become accepted that this is what's needed, whereas before it was just all about, you just got to know facts, and we'll work it out somehow in the end. But having to do an hour on Sunday, trying to get that across to half an hour on Sunday was absolutely impossible. I mean, that's just, I had to give a lecture on Sunday, but doing it in half an hour is impossible. Impossible.
Yeah, me and Gerardo were talking earlier about this and the contents of that course. I listened to the podcast the other day that you did on your book. But there's too much to try and talk about in one little podcast as one of the topics. I'd love to encapsulate it for people, but I suppose you just need to read the book, get the book and read it to get to the facts. What I want to ask, and I don't know if that's just a sneaky way of asking the same question, but are there the flip side of what you say, how you should do it? What are the most common mistakes that you see students and experienced vets make when it comes to clinical reasoning?
Well, I think when you don't have a structure to grab when you need it, because I'm not saying you need it all the time, but to know how to grab it when you need it, is so the mistakes that I see, either through referrals or second opinions that I see, or through stuff I've marked through vets. Students are a little bit different because in one way they haven't developed bad habits. You've just got to start to sort of get them trained up. But then so they're the problems that they're grasping or struggling with can often be dissimilar. So one of the things I do in my online course, which is running at the moment, is I ask the vets, what is it they find frustrating about difficult medical cases? And it's very consistent. It's not being able to see the wood for the trees, not knowing what's important. I think probably at least a proportion of cases that you see as second opinions that have gone wrong. Usually they haven't defined the problem properly, or they've overlooked something. Having what we call confirmation bias, really committed to, I think it's this, and only looking for the information that supports that and not looking for information that refutes it. One of the things I think is surprisingly common is a lack of curiosity to find out stuff. It's sort of this idea that you should be relying on your memory, even though, unless you're a medicine specialist, you shouldn't be walking around knowing every cause of hypercalcemia. But so many vets they either don't have the resources there, or they don't even Google properly. I constantly Google, and maybe it's because I did a PhD in the old days where there was no online stuff and you had to go into Index Veterinarius and you had to go through stuff and you had to frame your question and then you'd find other papers. But I'm constantly amazed by almost this lack of curiosity to have, I go into practices where the textbooks that are there are, 20 years old, they're what they had at vet school. And there's still nothing that replaces, there is still nothing that replaces easily having a Nelson and Kuto or Ettinger on your shelf. There just isn't. You can Google some stuff and you can Google quick questions and you can, but I still think and I just always amazed, and they go, they'll quote me a book and I'll go, but that's 20 years old. That's what you had at vet school. Don't you think something's changed? And this idea that, I don't know, that they don't invest in it. So, so I think falling into traps, being convinced about something, not defining the problem well in the first place, getting very distracted by not being able to sort out in a multiple problem case what's important. And then, here's another of my hobby horses, and it's particularly evident in Australia for an interesting reason, in that Australia was, I think, well ahead of the UK, and I don't know about the US, but I think so, in having clinical pathology services with quite comprehensive advice at the end of it, because I used to work for one in Sydney.
Yeah.
So DVL, what used to be, and, you know, all the rest of it. And so they've got good people working for good medicine people, you know, many of whom not clinical pathologists, medicine people who give advice. But what happens then is that then the vets don't look at the numbers and they can't interpret the ClinPath themselves. And so then, as sort of time moved on and more in-house stuff happens, so there's all the issues about how you make sure QA your in-house stuff. But then they seem to lose the ability because they never looked at the numbers. They only ever looked at the comment at the bottom. And when you lose that ability to be able to assess ClinPath, so what I say is that in small animal medicine, one of the absolute key skills is being able to interpret clinical pathology, you know, not necessarily cytology or hematology, but biochemistry. And that is, it's absolutely essential. And so there's that. And so the common mistakes I see is either ignoring something that's massively changed, but it doesn't kind of fit with what they're thinking, or then telling them that this value that's 1 point above the reference range must mean this. I had one last night where it said, you know, gamma GT was 15 and the reference range was 0 to 11, so I'd have to have cholestasis. And no, it doesn't. You know, so there's a mixture of things, actually. I don't think there's any one thing. And I think for people, the structure helps some of them to, you know, stop those traps, to remind them. And the other overarching one is where people really struggle, where I see people really struggle, is because they don't know their physiology. So they can't do their physiology, so then they really struggle with, and so that the area that really challenges everyone particularly is renal.
Okay, that's interesting. So if you say not defining the problem, do you mean literally listening to the history and then barking up the wrong tree? They chasing the thing that's not important, and then can be chasing it's not important, can be, you know, so I mean the classic example you give is that the owner says it's vomiting but actually it's regurgitating. Or the owner says that it's constipated, you know, the examples I give in the lecture, because it's straining. So not taking that first step to say what really is the problem here. So that's part of it, you know, animals that have bleeding lesions that have been worked up as being a local lesion when in fact they've got a bleeding disorder. That's a defining the system thing. It's a mixture.
Do you think that I don't know if this is a possible thing to answer, but could you give us like a short summary of the process of some people may not be aware of problem oriented. Like when I went through uni, and there was part of that process. We developed problem lists. We tried to define what the most localizing problem was and whether that was a true problem or not, whether the systems were involved. And then from there, like what diagnostic tests to consider to investigate that problem. And then from there, sort of generate differentials somewhere between all that. But what could you distill the process down somewhat?
Well, I'll tell you what it's not, and I think this probably helps. So what's a very common approach is, you know, these days most people know about problem lists, although it's surprising when we see, when I see people who are reflecting on having done the Certificate of Advanced Veterinary Practice, which is kind of like the memberships, and they reflect in their part of it on what they've learned. So many will say, you know, I really learned that creating a problem list is really important. But I think one of the really common thing that happens is that the clinician might say to the student, so what's your problem list for this case? Which is, okay, that's fine. And then they'll say, what are your differentials? And really what that is it's pattern recognition. It's saying, what disorders do I know of that will cause this pattern of clinical science, which is absolutely fine sometimes, lots of times, but other times it's not at all. And so what the problem-based structure is that you ask a couple of really key questions before you get to that differential list. You say, okay, what's the problem list? And on that problem list, what are the important problems that are going to be my diagnostic hook? I'm going to use the diagnostic hook. Am I sure I know what those problems is? You know, is it vomiting? Is it regurgitation? Is it fainting? Is it seizure? You know, all of that sort of stuff. And then usually, sometimes twistering a little bit, what system's involved and how? So do I have a structural problem of the body system, or do I have something outside that body system, where the body system is just the messenger for the clinical sign. And that's really important, because very often structural problems of a body system like the gut or the nervous system or muscles, you have to image them to find out what's going on. Whereas if it's secondary, it tends to be blood tests and all that sort of stuff. And given the fact that the most common clinical signs we see in practice are vomiting and diarrhea, it would be the most common in itchy dogs, itchy dogs or cats. Then, if you get that right, if you get the vomiting and diarrhea right, most of it will flow from that. If you get into your head that just because the other common mistake is you've got the dog that's coughing and has got a heart murmur. So instead of saying, I've got a dog that's coughing, does that mean it's got primary respiratory disease or secondary? Saying, I've got a dog that's coughing and it's got a heart murmur, it must be heart disease. I've got examples of, let's say we use this one for student teaching, where the cat comes in, it's got a history of recurrent gingival stomatitis that responds quite well to steroids normally. The owner usually notices the cat's having a problem because he stops eating and he starts to lose weight. Comes in, gets a shot of steroids, and it's fine. This time comes in, she'd noticed he was losing weight, but he was still eating fine. And what the procedure was that he then had all his teeth taken out. So he comes back having had all his teeth taken out, and the owner says, well, his mouth's fine now, but he's still eating and he's still losing weight, and he turns out to have hypothyroidism. So that's sort of not defining the problem at the beginning, because the problem at the beginning was weight loss despite a normal appetite, which is very different from weight loss because either can't eat or won't eat. And I think sometimes with the students, sometimes I honestly think they sometimes think it can't be this simple. I think they think I'm tricking them, but it has to be more complicated.
Yeah.
And it really isn't. And yeah, there's going to be cases that it doesn't work for. It's always the way.
Yeah.
But it works an awful lot of the time, and it takes out, one of the things I'm trying to kind of promote at the moment is that, given all of the issues around stress of new graduates, that the stress that new graduates undergo and their challenges with decision making in practice, some of the stress, yes, there's all sorts of other issues as well, but some of the stress is because they don't have this framework, and so they're faced with this, oh my God, I've got to remember all the differentials for this, or I don't know what's going on. What I'm trying to say is, if you practice this approach, it happens very quickly, and so you can use the rest of the consult to worry about stuff that's always going to be difficult. And you just got to accept that sometimes it doesn't work. Sometimes there are other rules. Sometimes the guidelines you give about whether it's primary or secondary GI disease. In the course that I'm running at the moment, there was an absolutely classic case of a cat that presented and it's been a bit off its food and it started vomiting. And so it was definitely vomiting. You really can't assess whether it's primary or secondary GI disease. There weren't any clues. So it's fine. Everyone said, don't know. And it turned out to have, so when they did bloods, it had these massive changes in liver enzymes and bilirubin was up and blah, 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 blah. And going, okay, fine. But it turned out to have a neoplasm in its duodenum that was blocking its bile duct. So it was an example of primary gut disease created secondary gut disease changes. Now, that's really unusual, really unusual. And it's important not to let a case like that, which you can explain, but a case like that put you off, because that's really unusual. So it sort of sits in that.
Yeah, that was really good, actually. I'm not saying actually, like, as if I didn't.
It's unexpectedly good, right?
I think, like, through that, you talked about examples of clarifying what it is that's important about using the problem list and how to use it, the questions to ask, but also you gave us classic examples, great examples of how to use that as well. So, and where people get caught up on. So that for me kind of summarised things quite nicely, I thought.
That's lovely.
One of the things that I say is, if you don't ask the question, then how do you know when you're going to get the right answer? And what I see, and I guess when you go back to what you said before, what common mistakes do you see? And I see this a lot in countries where their small animal training has been very, very poor or non-existent. trying to learn all this stuff on a very shaky base, is that, but this also happens in UK and Australia, is they're very driven to do something without stopping to think. And when I talk to ECC people like you guys, and in ECC you've got to do things quickly, but what our ECC people say is, look, if it's going to die in the first 5 minutes, it's going to die anyway. Yeah. So stop thinking, just a little bit about defining that problem. I mean, obviously, and sometimes you're moving into doing your generic, I've got to save this animal's life bit. But while you're thinking about, so what really is going on, what's happening. But that drive to do something without stopping and, to give drugs, to give something. But I see that a lot in countries where their education's really poor, so they're trying, but there's this relationship with the client where the client expects them just to do something, and just give drugs, and you go, whoa, just stop and think about what's actually happening.
I have an example of that. I can't say the exact details because I can't remember the exact details, but I sometimes get messages from people in other countries. They'll just spamming the history and the results and things like that, and then part of that they will also put down all the medications it's on. And it's like, well, I don't even know if you know what you're treating. Like, what are you actually treating with all this drugs?
I know.
That's a lot of things there. There's like 10 different medications. Some are natural, some are not natural, some are... And like then there comes back, so sometimes I reply back and it's like, what diagnostic test apart from that?
What do you actually treat?
And it's like, oh, we haven't done that. What's the next test? So...
And I think we're, certainly with medicine, is in that where errors lie is in not taking the history properly. There are so many times where I'll get a vet who describes a case to me and says this happens and all the rest of it, and I think this seriously doesn't make sense. This can't be right. It just, something's missing here. You've missed something. Missed something in the history. You've missed something in the physical exam. It just doesn't make sense. But so that history taking, which is where the problem-solving approach really is a framework, because it means that if what your guiding principle is, I need to define the problems, know what they are, define the ones that need defining, and think about what systems involved and how. That structures your history taking. So you don't just walk away saying, oh, the dog's vomiting, or the dog's got diarrhea, or whatever. It makes you get enough information so you can say, yeah, I'm happy it's vomiting, or gee, it's absolutely fine for a week and it just started vomiting today and it's just bright and happy. It's going to be primary GI disease or possibly pancreatitis. So it's that history taking. And if I think of the number of students who have come out of the consult, come back to me and said, yeah, the dog's vomiting, I'm happy it's vomiting, good, that's great. And what's its appetite like? Oh, it's not eating. And I'll say, when did it stop eating? Oh, I don't know. But when it stopped eating is hugely important in how you assess vomiting, because if it stopped eating a month ago, then that's a very different deal than if it's been vomiting for a week and it stopped eating yesterday, and that's the reason why the people brought it in. So it's that recognition that, and I suppose one of the things that it tries to help is we're all absolutely prone to taking notice of what we think is the most important problem and forgetting about the stuff that's around it. But the stuff that's around it is often got all the clues about how you assess that. So, yeah.
Some of my biggest complaints have also been noticing all the important stuff, but then forgetting about what the owner actually came in for. So you get those cases where they come in for a skin problem, and then you find the tumor and you do the surgery, you fix it, and you're a hero, and then goes home and it's still itchy. And the owner said, but you never fixed the bloody skin.
Exactly. And one of the things that we say, and I know that our vet, who's the head vet at the Beaumont and runs our sort of our rotation there, what he will say to the students is that when you say define the problem, one way you can interpret that is, what is the owner really worried about?
Yeah, exactly.
Yeah. The sort of advice that comes from the consultation models about, the golden 3 minutes, just letting them talk and just finding that out, because it's so, and but it's tough, and 10-minute consults over here, 15 minutes if you're lucky, which means that my argument is you've got to be even better at clinical reasoning than specialists who've got an hour.
Yeah.
You do practice at the moment a couple of days a week, Jill? Is that right? You work in
I
practice?
do a sort of half a day at our first opinion practice here. I try and do it every 2 weeks, and I do one Saturday a month at a local practice. I used to do every second Monday evening, but it's just really impossible. So I do a little bit.
Yeah. And are there things that still challenge you? Surely by now you know everything now. What do you still find challenging about practice, whether it's clinical or non-clinical?
Eyes. I hate eyes. I hate eyes. So eyes always challenge me. I do the programming for London Vet Show, and one of the things I say, which isn't entirely true, but is that the way I program it, what certainly influences my programming is what terrifies me when I'm there on a Saturday morning and something comes in and I think, or if I had to do it, so, and because I run the CBD unit here and I, see what works and what doesn't and what people want, I'm more and more convinced. In some parts of CBD, I'm not saying all of it, it's not, this shouldn't be the only thing that CBD is, but there's still an awful lot out there of just really wanting to understand the fundamentals of things. Also to understand advances, for sure, but, we've had people come to our course. We run a course pretty much every year on the exploratory laparotomy, and we say, this is the exploratory laparotomy, it's a practical course, and it has topics like, oh my God, it's a big fat bitch spay, or the abdomen's full of blood, whatever. So it's really fundamentals of abdominal surgery, and it is our most popular surgical course. And we have people come to that who've been in practice for 20 years and learn, better techniques about tying off ovarian pedicles and things like that. So I just think when you're in practice, you've got to deal with so many body systems and so many things, and specialists lose sight of the fact that they're only dealing with, one thing, and when you're in practice, you're dealing with, I'll see a wound and I'll go, gosh, is this going to heal? Is this not going to heal? What would make it not heal? So that's kind of, whereas, if I see a dog that's got diarrhea or vomiting, it's fine, I'm fine. It's not a problem, but the other stuff, yeah.
It's funny you say eyes. So my career started in general practice because I wanted to be a dairy veterinarian that did smallies, right? And I love the idea of it. Cattle were just nice to work with, especially dairy cattle and the green hills and so forth. And ended up becoming a small animal practitioner. And I learned a lot of stuff at a certain level. Like I wasn't good at any kind of further, at managing any sort of advanced presentations of common diseases. That's where we just refer to the place that actually I work at now. And but what I did though is I tackled a lot of skin, ears, and eyes, and so forth. And one of my colleagues who went straight into emergency is terrified of skin and eyes. It's 10 years out. It's just like, what I do about skin and eyes, I'm just like, this is stuff I learned like for 6 months in general practice, exactly. Right? But she would tackle a GEV
without a problem. It's really it's interesting. And I don't think it matters how long you're in practice. You'll still see stuff that you go, I have never seen this before. Like, never seen it before. This is weird.
My Achilles heel is neurology. Like, is there vestibular disease? I've got that. You're a little bit wonky and doing intermittent stuff. Okay, now we have to go back and really kind of like read some textbooks now. Let's localize the problem. That's like,
But see neurology, if you know, that's another example. I mean, if you if you're reasonably comfortable, and you don't have to know the deep bits of it, but if you're reasonably comfortable about what goes wrong, localising your lesion, then you're fine. I mean, I was at a meeting in Sweden a couple of weekends ago, and one of my colleagues from here, one of the neurologists, was there as well, and I was doing some stuff on clinical reasoning, and the whole day was more on mind stuff, stress and learning and things like that. And he did, and I've never listened to his lecture, but he's got his aim is to stop this neurophobia. Yeah. And he just gives this really lovely lecture, and Holger Falk, who's one of the co-editors of the book, he developed a structure which he calls the 5-finger rule, which is, it still defines the problem and system and location, but then the 5-finger rule really helps you in deciding the lesion. And it really makes a whole lot of sense. And I think one of the things about neurology is that you get this feeling that you're supposed to do this amazingly complicated neurological exam, but actually, do you know what? It's sort of, honestly, what's the proprioception like? Do they have proprioceptive deficits? Is there any lateralization? You can do a bit of reflexes. I can never remember the cranial nerves, but if I saw that there was something different, I'd go and look it up. Yeah. And then it just goes, okay, well, once I know where it is, then is it painful? Is it progressing? Is it lateralizing? Is it resolving? It kind of really helps you narrow it down. You should go to his lecture. His lecture's great. And it's very specifically, he says, there's a word for it. Anyway, fear of neurology. It's a well-known thing, and there's lots of papers on it in the human nutrition.
Well, I think I got that.
Yeah.
It's especially late at night, and you get a complicated neuros case, and you just go, oh, geez. No.
The feeling that you have to do 14 steps of a neurological exam. I can never remember them. Apart from talked about, is it central, is it peripheral, is it proprioceptive, is it lateralizing? It was like, it's kind of what I do,
That's kind of where you get. And the other stuff, I think where we get terrified is all those cranial nerve things, and what happens if, this is what I find, what happens if I put a pin here and it doesn't react? Which one's that? Is that trigeminal? Well, facials when they droop, okay, blah, blah, blah. And then the crossing over, so therefore it's on the, anyway. Yeah. But, yes.
I think it's very, very valuable if we think about Gerardo deals a lot with younger vets or vet students, and the people we interviewed before this. A major concern is that feeling of, I'll never know everything, or I don't know enough. And then to hear you say that there's stuff that scares you, and it's not. I think it's a nice message to say to people. It is always stuff that's going to scare you, and even if you're Jill Maddison, you won't know everything. But it's not as.
I try to put it in the context that, one of the things I say about the problem-solving approach that we teach is that, left and right brain stuff has kind of been discredited, sort of, but I still think you've got an emotional side of your brain which can be really activated when you're stressed, even if you're not normally an emotional type person. So you're really activated when you're stressed because you're stressed about what you're doing, you're stressed about the client's stressed. There's a whole lot of emotion flowing in that difficult consultation for whatever reason it is. And if you have a structure that you can say, just grab onto that ladder that pulls you into your problem-solving part of your brain, that takes you away from that emotion. And you go, okay, well, all right. And I show a slide, I didn't show it on Sunday, but there's a slide I show the students when I give the lectures, and it's a really lovely, I need to find out where it's from. It's a staircase somewhere here in the UK at university. And then it's got a quote, which is from Martin Luther King, saying, it doesn't matter if you can't see the end as long as you take the first step, and it's got it on the staircase. And for me, being able to say, okay, right, let's just define the problem, what have we got, have we got evidences, let's just make sure we've got our problem list. And grabbing onto that ladder to me is an analogy for, I'm in this soup of stress, I can grab onto this and kind of pull myself out. And then at the same time, it helps you communicate with the client so that you're a bit clear about, the sort of the consultation skills that, you get taught about signposting. You're signposting, you say, right, well, I'm just going to, and it just, I think, helps with that.
Absolutely.
Yeah, give you something to, as you said, yeah, it's a ladder. It's a recenter, to then sort of solidify, not even solidify your thoughts, because as you go through that ladder, and as you talk and as you kind of reason, then things start to solidify. But it's just
and then when you've got to go and look something up, and I mean, as I said, I Google all the time. So I saw a dog on Saturday, and it's a cute little 6-month-old Maltese that has had 2 acute episodes of right forelimb lameness. I hate lameness too. So I hate that's. I hate it. 2 acute episodes of really quite marked right forelimb lameness that really seemed to be related to the shoulder. Recovered from one completely, both in the snow. Snow was this week. And I was thinking, if you were a Labrador, I'd be worried about OCD or something like that. So then I Googled, what breeds get OCD? I don't know. And of course, for me, big breeds come up, so I'm going, well, it's a Maltese, it probably isn't. But I still think if it happens again, either this dog's just been really unlucky, she's crazy and running around with her litter mate. But, there's that, you just can't model, particularly I've never been very good at what breeds get what. And because partly I've not untrained myself about it, because that can trap you in a pattern. So I've gone too far the other way, actually. So I'm really bad at knowing, something like, it's a key sound, okay, so it's likely to have hyperparathyroidism or something like that. But I try to train myself not to do that, which sometimes lets me down, because I think, I don't know, is that happening in this breed? I don't know.
I get like that when like older dogs come through, like 12, 13-year-old dogs come through and they've had a collapse episode at home, and they come through and for me it's almost like, hemabdomen, it's kind of like it's a pattern that I've seen so many times with clinician. Having hemabdomens you see, but it's kind of like add hemabdomen to a differential list, but consider these other things. It's like you can use sometimes pattern matching to help shortcut, but it's not. It's as you said, it's not to get trapped down that this is what it is. It's something else, because otherwise, as you said before, you get stuck. It's not that. Where do you go next? You haven't thought about anything else.
So you either you get stuck and it's not that, so you haven't thought about anything else, or you keep pursuing that, which can be to the detriment. And the example we talked about yesterday was about the dog. It's really the entire female dog. It's unwell. Blah 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 blah. Of course, you've got a PIO at the top of the list. But if you go, it's a PIO, and don't think about anything else, and when you can't find that PIO in your imaging, then either you'll start going, what is that? Or sometimes you take it too far and it goes to surgery and there's still no PIO there. So it's kind of a, I think it's a safety net. And it was interesting because after that talk yesterday, one of our students, I was talking to him about, his experience on EMS. He said, really worked for me because I saw this dog and it presented and it was vomiting and had abdominal pain and all the rest of it, and SNAP PLI was probably not what that means anything, but anyway, so
we don't stop that anymore.
Exactly. Waste of time. But so judgment was pancreatitis. Went and did a scan, but the pancreas was normal, and the student said the vet was really stumped and said, but I'm sure it's pancreatitis. And the student said, so I used the problem-solving framework and said, well, something's going on, it's vomiting, so it's either primary or secondary GI disease, so let's make sure that the guts look okay and some other organs. But he said the thinking was there, whereas the vet was kind of, oh my God, which is also a knowledge thing. Not all dogs with pancreatitis will have abnormal ultrasound findings. So, it's just...
So would it be fair to say with pattern recognition, because as Gerardo says, it's handy because it can save you time, but instead of pattern recognizing and saying, okay, I need to go and prove that it's that, to rather change your frame of mind, and I'm saying this for myself now, to say, well, the first thing I need to go and rule out is that. So you say you see your classic hemabdomen, and you go, okay, the first thing I need to go and rule out, not prove, disprove, is an hemabdomen, and then you scan it and go, yes, it is. Okay. Or if it's not, then you go, okay, well, So.
I think that's a good way. I mean, I'm not hugely fond of the rule out system, which means you have 10 different, you rule them out, but absolutely that difference between I've got the collapsed dog and it's a German Shepherd and it's pale, So therefore, of course, I've got a collapsed dog, it's got pulmonary membranes, it's anemia or poor perfusion. If it's anemia, bleeding or hemolyzing, it's a German Shepherd. My first thing is that it's bleeding, it's a hemoabdomen, but I've actually just said it's hemolyzing or bleeding. So if I can't find that bleeding, I immediately go, is it hemolyzing? And I've got a case I use, and all my cases are real and they've all been seen in general practice, as I said, but I've got a case of a dog who presents collapsed and has pulmonary membranes, blah, 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 and it's a Labrador, I think it's a Labrador. I changed the breed, but I think originally it was a Labrador. And or was it a Rottweiler? Anyway, it doesn't matter. One of those breeds. And it turns out to have Evans syndrome. So it turns out to have hemolytic anemia and thrombocytopenia. And it presents with a bit of melena. But when I do that case using Turning Point, anonymous voting, quite understandably, there are people who will say, my first thought was that it had whatever. And then when you say to those people, fine, but how are you going to explain the melena? They go, I don't know about that. But I've had some people, I remember one person on one of the courses going, but I saw a dog like that and it had a hemoabdomen. I go, I know, of course it did. But this dog didn't. I promise you it didn't. And they'll fight you and the dog, and then I've got another dog that I use, again, real one, which has PUPD and is unwell, and it's an unneutered female, and it's been unwell for a few 10 days or so, and it's got a bit of diarrhea and things like that. Anyway, so of course people are, is it PIO? Fine. But I have people get really upset with me and say, but that dog could have a PIO. And I go, yes, but it didn't. I don't mind. But what you said, I need to make sure this dog doesn't have a PIO, of course. It's like hyperadrenal autism. Even at the merest whiff of a possibility, you want to rule it out, because if you miss it, but you have to have something to back you up, because otherwise you have the potential to take it too far.
How are we going for time, Jill? Oh, I don't want. I could talk to you all day.
Oh, we're sort of getting there. But
can I ask?
When you're talking about yourself.
I know.
Oh, no, this is awesome. Thank you for sharing.
Can I ask about books? Jill, you mentioned earlier Nelson and Ettinger's and then of course your books. Have you got any books that you recommend, and they don't have to be clinical, even if it's another book that really helps you, or that you recommend people read? But I would like your opinion on the best clinical books as well.
Okay. I personally, from a medicine point of view, so I'm just doing medicine. So I always have the latest edition of Vettinger and of Nelson and Couto. So, small animal medicine. And I like Nelson and Couto because I just like the way it's laid out. I find it easy to find things. I quite like narrative. But I like having Ettinger because if I want to read up about a disease, so I tend to, with Ettinger, use it and go, I now need to read about X disease just to see if things fit or whatever. Ettinger's not as strong on pathophys as it used to be, which is a bit of a pity.
Okay.
Mind you, I haven't read it cover to cover, but so that from it's interesting. I mean, there's sort of books out there. I read a book called Street Lights and Shadows. I think that's what it's called, and it was about how people make decisions, and there's that Fast and Slow Thinking book, which I have to confess I haven't read. And there's things about that I quite like, but I have a terrible confession to make, in that I was asked to write a chapter in there's a book that was published last year or in 2017, I can't remember, on veterinary medical education, edited by a friend of mine, Jenny Hodgson, and a colleague of hers in the States. And she asked me to write a chapter on clinical reasoning, or teaching clinical reasoning. And I said, yep. I thought, I better do this. And then I thought, I better read the literature, because I'd never read it. I'd never been informed by the literature what I do or what we do. And so, and I've always been, I haven't really liked the educational literature. I can't really understand some of it. And I find it quite opaque and difficult to get into. So I thought, right, well, I better. Now I really need to, I can't just say stuff, I've got to reference it. And what was really interesting was that I think it was a matter of time, but everything I read about just supported what we were doing. But if I'd read that literature 10 years ago, it probably wouldn't have. Like, it's really evolved to recognising, you know, dual processing and a combination of pattern recognition and all that sort of stuff. And there's arguments about, you know, the fast and the slow thinking and what's more accurate, but I don't think that's relevant. So I found it quite good that I was able to find, maybe it's confirmation bias, able to find studies that sort of supported what we do, or reasons why what we do, because there really isn't anything out there else that tells you how to analytically reason. They just talk about analytical reasoning and say that's what clinicians do when pattern recognition doesn't work for them, or they're faced with something unusual. You know, there's stuff about how doctors will be talking when they're seeing a common case, and as soon as they see something that's not common, they stop talking because they're stop talking to their students, they're thinking more analytically. So the thing that, to me, we've been able to do is to just provide a bit of a structure about how to analytically reason, because before that, all it really was identify the problems and think about every single differential that goes with that problem, and that just doesn't work.
Well, differentials bombing are quite fun, hey?
Yeah, exactly. I mean, gosh.
Yeah.
So from a book point of view, I love Caitlin Moran, but that's all about feminism, not about clinical reasoning.
Doesn't have to be clinical. Any books? It doesn't have to be clinical.
I'm a collection of her works and things. Yeah, I've got a girl crush on her.
Sorry, who was that? I missed the name.
Caitlin Moran. She's a writer in the UK.
Okay, cool.
She wrote a book called How to Build a Girl, How to Be a Woman, and she writes in the Saturday Times a column, and she's just incredibly funny, but really insightful about, you know, gender issues and stuff. I just really like it because she doesn't take herself too seriously, but she is really serious, but she's very, very funny.
Well, it's awesome you share that, because 90% of people who listen to this, you know, so there.
I just find it. It's really good.
Caitlin Moran. Okay, cool. Thank you for that one. All right, Gerardo, anything else?
I got one last question, hopefully, and then we can ask those other questions, the shorter ones. But I always get asked, should students go spend some time in practice? Should they go straight into what they choose to do based on what they've, you know, seen and love, or should they go to a rotating internship?
Yep. Okay. So, and I did an internship out of uni, which I think in the circumstances was fine, because Sydney at that time was a mixture of general and referral practice. So you saw lots of first opinion stuff. And I also at the same time worked in practice, but I would strongly recommend that nobody goes straight into an internship. We won't that's probably unfair. So here, we now will not take our small animal interns straight up out of vet school. They have to be up for 2 or 3 years. The equine and the farm ones can be. And I think it depends, because I think in equine and farm, my sense is, and I'm not really experienced, my sense is that the internships are seen as more of a kind of, here's another year to get you structured. And if the internships were like that, but I just think to get the most out of an internship, what I always say is, you want to get some of that just basic stuff under control. You want to be able to get a vein. You want to be able to put in a catheter. You want to be able to put a neuter. You want to be able to, you know how to talk to clients, you know, just get that stuff. And then while you're doing your internship, you've got the more capacity to learn the stuff that you're there for your internship. Now, our interns here kind of run hour after hour service. So it is important that they have some smarts on board and some confidence about being able to do that. But even so, I think, and then I also think longer term that not having been in general practice ever makes you not as good a specialist, because it makes you not aware of the challenges that you face in general practice. And I think it makes you might be a brilliant specialist, and you might, you know, your experience in small animal practice and in general practice then really informs a better understanding of what everyone's out there facing. And I think one of the things where specialists can become a bit arrogant or whatever, is to, how did this happen? How did it get to be like that? Well, I know enough now that by the time the animal gets to the specialist, all sorts of things change. Yes, sometimes it's gone terribly wrong, but often things have really changed. Something has become a lot more obvious. The clients have behaved very differently with the specialist than they did with the general practitioner. They come with a different mindset. There's a whole lot of things. So I think having that experience in general practice, and from the point of view of if I'm looking at for people who are going to either teach our students or lecture to general practitioners, I want them to understand those challenges. So when I program on the vet show, I say to the lecturers, you might be top of your field, but I don't want to hear about that. I don't want you to tell me what cool stuff you do, because that's not really of interest. What I want is you to be able to use your experience and your knowledge to help practitioners do the very best job they can do in the practice. And that doesn't mean just referring to you. So my most challenging lecturers at London Vet Show have been those who stood up and said, so beyond this tiny bit, it's all really complicated, you should refer to me. And then that's not very helpful.
No, we just can't do any of the stuff that they're actually talking about. Yeah.
Exactly.
That's the best answer I've heard to that question.
It is, and it's just like Jill's lectures always are. It's decisive. You listen to what she says, and that's what I said at the beginning. And then you walk out of that lecture, you know exactly what you need to do. Jill, we normally wrap up with the one question. So you're at a congress and you've got all the world's veterinary new graduates in a room, and you've got 2 to 3 minutes to give them one bit of advice. What would you tell them?
Oh, wow.
Should have warned you about this one.
Well, it's probably what I always put. So for our yearbook here, in the final years, I just go define the problem. Honestly, truly, I know it's if you define a problem. So the analogy that I give is that if someone rings you up, your friend rings you up, or your partner rings you up, or whatever, and they're crying on the end of the phone, crying, please help me. The first thing you ask is, what's the problem? So if you can define the problem, even if you don't even go into defining the system and things, is to define the problem.
Okay.
Listen and define the problem would be, so if I had 2 to 3 minutes, I'd say listen, active listening.
Yep.
And as the guide to that, what you're aiming to do is to as the start, is to define the problem, be it the animal's problem or the client's problem or both.
It's actually really good business advice too. The amount of times where you're tackling some kind of fire and you have this idea of actually what the problem is, but as you actually look into it, it's something completely different.
Yeah.
I like that. That was really good.
That's great. That's a great spot to end.
Right.
Thank you so much, Jill. I'm honored. That was really lovely. I think that's going to be very, very useful for a lot of people. Thank you so much. Gerardo, thanks for organising.
Thank you for inviting me.
Okay, thank you again to Jill. What a legend. Now, let's see what we can apply. I have to say, and this is just a thought that struck a chord with me personally, that I like what Jill said about not doing something because it seems too hard, and that maybe that means that you don't really want to do it. For a very long time, I wrestled with the idea of specializing because it seemed like the sensible next step in my career. But I always had 100 excuses why it's not a good time to do it, and to be honest, it just seemed too hard. And to hear Jill say that just brought home to me what I'd probably realized a long time ago. I clearly don't really want to specialize. Otherwise, I would have started a long time ago. And it's actually quite a release to say that. I don't really want to do that thing. I can let go of that idea. Is there anything that you're struggling with that maybe you just don't want to do?
Jill talks about defining the problem and how to do this. You need to ask, and then you need to listen, then listen and listen. But many of us don't know how to actively listen. So here's a quick guide to active listening. In case you haven't heard this elsewhere, there are at least 5 kinds of listening when we talk about active conscious listening. So the first, listening to disagree. This involves identifying words, phrases, and ideas that you use to disagree with the other person you're listening to. Clearly not helpful. Listen to respond or record. This seems on the surface to be a very helpful form of listening. However, it diverts our attention to our own thoughts, experiences, and stored memories. Finding a helpful question or suggestion may seem appropriate, but what often happens is that the client's thinking regresses as they talk, making our intended intervention obsolete before it is even voiced. So, also note that taking notes as the clients speak is also highly distracting for both you and the client. Listening to understand. Now we're getting there. Here you focus on intent. What is the person trying to say and why? What overt and hidden implications are there? Fourth, we have listening to help the other person understand. This goes a step further in that it shifts your attention from yourself to the client. Here, we help the client become more aware of their own thinking processes and the meaning that they attach to the words and phrases, including the emotional responses that are affecting their behaviors and decisions. Finally, listening without intent. This aims to simply to support the other person in the conversation that they need or want to have with themselves, with minimal intervention. This is not necessarily appropriate in a clinical or consult setting, but is still a good goal to aim for with relationships with your colleagues or in some areas of your personal life. So here's what we need to do. For the next week, when you are in a conversation, be aware of how you are listening. Where do you fall between levels of listening from 1 to 5? And then try to aim for the next level up.
And that's it for this episode. If you liked it, we'd like a 5-star review on the iTunes store. Or if there's something else you'd like us to talk about, get in touch. Hit us up on Instagram or click on the link on the episode to find out how to get in touch. Now, get out there and go smash it.